really want to make this a discussion as much as we can. So feel free to put questions in the chat or comments, and we can even, have, if we want to even have discussion around a particular topic. We love to engage in that as well. So yeah, this is meant to really be a springboard for dialogue. So with that, let me share my screen and we'll get started here. Okay. All right. So, as was mentioned, I wear a few different roles, and they all kind of fit together for me. But it, it's sort of the MGH ways. You got to have all these different hats, and you got to be, and that's how people know you. And so you're known in one hat or another. But for me, it's all one job. And my area has really honed in a lot, thinking a lot about healthcare provider resilience and well-being. Many of you are very familiar with the statistics. In our case, what I'm hoping to show is just to show some pilot ideas that I think have worked well. And by no means is it comprehensive or exhaustive, but I think this is just an idea of like what has worked well, why do we keep doing it, and then what are some new ideas that we hope to infuse. So, and I want to think of it as a sort of in the think about both from individual and organizational strategies. A lot of my work, just to be very explicit, has been on individual strategies, but organizations are made of individuals, and I think we also just want to be right from the outset say that there's organizational responsibility in thinking about this, and how does an organization think about this? So I think they both have to operate in parallel. And there's some people who are experts at sort of in-basket management and doing other organizational, like reducing administrative burden and maybe even thinking about student loan debt. And I think those are important issues that also they must be addressed in parallel with some of the individual pieces. So I have no disclosures or financial interest to report. I guess just to be fully, I do write a chapter for a textbook, and I do get a small honorarium for that work, but it doesn't affect my talk here. So what I hope to do is really talk about the learning environment. We'll talk a little bit about epidemiology and consequences, solutions, and future directions. And I'm going to weave in these next minutes that we have together, sort of also weave in my own narrative, because I think what's important to recognize is that we are no different than the people we serve. And I've come to appreciate that much more wholeheartedly. And so as I began to talk about my own journey, it has helped me understand a little bit more about others' journeys and also and how collectively we can come together with ideas and solutions. I just want to point out these two. So just take a moment to pause. And some of you may recognize one or both individual, but on the left is Dr. Skip Atkins. He's a beloved primary care provider at Mass General, worked in the community health center in Chelsea. Those of you familiar with Boston, Chelsea is sort of one of these gateway towns where there's a tremendous immigrant population that is settled in there, and it's just right adjacent to the city of Boston. And he really was dedicated to sort of one of these pillars, would be active in both the sort of the politics of the town, as much as was obviously a primary care provider. On the right is Dr. Lorna Breen, who was a frontline worker, healthcare provider in New York City at NYU, and was, again, beloved, passionate, was one of the, be willing to step in right from the outset with COVID, when the COVID pandemic hit. And they're really regarded as dedicated providers by both the countries. So what was common between both of these individuals? They're both beloved, they're both passionate, they're both dedicated. The people you want on your team, essentially. What is also common for both of them is that they both died by suicide. And this is pretty well publicized. This is in the New York Times. Top ER doctor who treated virus patients dies by suicide. The first line is from her father, was that she tried to do her job and it killed her. This is actually the foundation that was created by her family, and has done a lot of legislative work around healthcare provider well-being, particularly at the national level. And this is a stigma compounds consequences of clinician burnout during COVID-19, a call to action to break the culture of silence. This is a beautiful piece in the Annals of Internal Medicine that was written by Skip Atkins' brother, also a physician. And his one statement in there that really stood out for me is that, how could a doctor who meant so much to so many take his own life? And this was at the memorial services that were done in honor of his brother. And then this was written by a colleague. Doctors die by suicide at twice the rate of everyone else. Here's what we can do. So one of the interesting things about this is that how transparent are we about this phenomenon? And just thinking about it, at the tip of the iceberg of, we think about suicide as being the tip of the iceberg. That means there are a lot of people who are tremendously affected by the profession, but may not be for a whole host of reasons, may not be at that level of really intervention, but are tremendous. They may not show up to work in the way it's just how presenteeism, we call it, like how present are they? And it turns out in medical schools, there's no requirement to really publish or talk about this. It's sort of stigmatizing already to begin with, because there's lack of reporting of data, and very few studies on thinking about this. And obviously some of these signals can appear early in the healthcare trajectory. I'll just say from the other thing I'll say from the outset is a lot of my comments will be talked about in a physician sort of centered view, only because that's what I've grown up with, but I will present some ideas just in other healthcare professions. But I just want to say that I think it is, though, definitely applicable to the whole sort of range of healthcare workers in our academic health centers. So this is one of the main issues. So let's go through some definitions, because I think sometimes people use these words and it's not clear as what is meant. So burnout, you hear that word all the time. And it is a syndrome that is conceptualized as resulting from chronic workplace stress that has not been successfully managed, characterized by three dimensions: feelings of energy depletion or exhaustion, increased mental distance from one's job, or feelings of negativism or cynicism related to one's job, reduced professional efficacy. So burnout refers specifically to phenomenon in the occupational context and should not be applied to describe experiences in other areas of life. So it's an occupational syndrome, so it is not a clinical one. And oftentimes it gets talked about as a clinical syndrome, but just want to be clear. Now, it may be related to other clinical syndromes for sure. Occupational stress refers to harmful physical or emotional emotional responses that occur when the requirements of the job do not match the capabilities, resources, or needs of the worker. And occupational stress, when we think about it, there are factors intrinsic to the job, like poor working conditions. And in COVID, we actually experienced all of this front and center, right? What was the working conditions, work overload, time pressures, physical danger, the role in the organization, role ambiguity, role conflict, who was responsible for again, if we think about the patient, responsibility for people, conflicts regarding organizational boundaries, career development, or promotion is an issue that has been talked about, especially in academic health centers, not being promoted oftentimes, a lack of job security, relationships at work. If you don't like who you work with, that makes it hard to come to work. Difficulties in delegating responsibility, and then the organizational structure and climate, having the ability to have participation in decision making, the politics, the local politics that are there, financial challenges. So that all affects the individual, and that gives a sense of anxiety. And there's how able are you to tolerate ambiguity? There are extra organizational factors, family problems, life crises, and then that can affect, have direct effect on health outcomes and health consequences. Now, just so that, again, this group may be familiar, but I just want to make sure that we're all on the same page. The rate of suicide, death by suicide in physicians is 1 physician a day in the United States. This is, as was mentioned, twice that of the general population. There are higher rates of depression, emotional exhaustion as well. And this affects not just healthcare, not just physicians, but also affects nurses and other healthcare professionals. So, and there are sort of gender disparities here in female physicians. The rates are higher than other females. The general population, they're also higher in male, but you can see there are differences in the rates as well. So one of the things that we also know that in the COVID pandemic, we actually had a dramatic rise. I mean, this isn't surprising, but it's been documented. We see the dramatic rise in emotional exhaustion and depersonalization. And the rates of burnout went from roughly 40% in 2020 pre-COVID to, at the end of 2021, to 60%. So this is just staggering. And in the population, it stayed stagnant. The general population rate of burnout is around 25%. In the satisfaction with work-life balance, you can see that it remained high in physicians. They do have tremendous satisfaction. So again, those that are there, again, it's this, you can have both. One of the interesting things is that you can still have both of these phenomenon coexisting, satisfaction and burnout. We actually, it turns out, do a good job picking the right medical students to enter the profession. They actually, when matriculating medical students, are much more resilient and less distressed than their peers when they enter medical school. And so you can see on this scale, they have lower rates of burnout, lower rates of depression, and lower rates of a sense of well-being, overall sense, higher rates of overall well-being. And then the predictors of burnout really boil down to, sense of the mental quality of life, emotional quality of life, physical overall quality of life, as well as, just looking at if they have a positive depression screen, that obviously is a predictor of burnout. We do know that there are high rates of alcohol use, and these are comorbid, burnout and alcohol use and dependences. There's a high overlap as well. And we also know that the other things that predict burnout is, whether they have a partner. Younger physicians are higher risk than older ones, having high levels of debt as well. There are differences both by race and by ethnicity in burnout, and part of this is sort of another interesting take that people are now exploring further, which is looking at sense of how does discrimination, prejudice, sense of isolation, the cultural differences, how they all contribute to feelings of burnout. So you can see here, some of the things that really struck me. This is in this study in the Archives of Internal Medicine, saying that, always the token and the represent, never fitting completely in anywhere I went, from quickly establishing meaningful relationships in college to barely maintaining loose acquaintances in medical school. Another one was, I feel that people condescend and stereotype me and assume I'm another minority who got in via affirmative action, when the reality is that I was admitted in the top 4th of my class. Now, in medical students, we know that over time, they start out quite good. You can see here at the beginning, low rates of burnout. And then this is in sort of older models of medical training, where there was like first 2 years were typically a classroom learning, and then the last 2 years were in the field or clinical education. By the end of year 1, you can see that it becomes much higher, then it kind of drops over the summer, and then it kind of peaks back up into end of year 2 into year 3, which is typically when people are in inpatient services, depending on the specialty. And then finally, it does recover in year 4, but you can see it doesn't recover quite to the degree at where we started in year 1. And when we look at diagnoses of students, the students are coming in, in their student health centers for things like depression, anxiety, adjustment disorder. So that creates the bulk of it. And then other conditions like attention deficit disorder, eating disorder, and substance use disorder. And I imagine here in this audience, everyone has had some experience around these diagnoses. So what is happening in the medical education environment? Students experience intense stressors and pervasive perceived mistreatment. And as a result, they cannot resolve the normal developmental psychosocial crises of identity and intimacy. Their lifestyle and psychosocial sacrifices. There's a shift to a more cynical and hedonistic orientation, resulting in significant elevations and increases in depression and anxiety. And again, one of the things I'm always struck by is that, I've read a lot of personal statements, both for residency and medical school, and rarely does anyone write, actually, I've never seen a personal statement where they say, oh yeah, I'm doing this because I want to make money. Now, granted, being a physician does offer a particular type of lifestyle and for many people, a particular financial sort of compensation model, but rarely does anyone even talk about that. And somehow we shift having to think about that all the time. And so there's a sort of alignment between the values of why we entered medicine and the reality of medicine. And the diversity, there is a lack of diversity of coping strategies because not all of them are good. So for example, as many of you know, usually around an exam time or after exam time, there's a significant increase in alcohol consumption amongst, I saw it definitely in my medical training. And it's not a good one necessarily. And so it appears as though graduating medical students are worse off psychosocially than when they entered as first years. And one of the things that's most striking here is like, as people are more burnt out, the number of cheating or dishonest clinical behaviors reported also increases. And this is we are producing healthcare providers to enter the workforce. And if by virtue of this process, they're going to be a dishonest worker in the healthcare workforce, that is something alarming to think about. This is just give example in certain other, like this is not just, I look at neurosurgeons and you can see that they also have high rates of burnout as well. And, this is example of just an example where they were least satisfied subspecialists when it came to satisfaction with work-life balance. And satisfaction of work-life balance is both positively correlated with career satisfaction and negatively correlated with development burnout. So the question is, how do you addressing the satisfaction of work-life balance? Because we need to have you want to have work, so you're not bored, but you don't want to be overworked, right? And that you can spend time with your loved ones and family and other things that you enjoy doing. And it turns out that higher levels of burnout and lower satisfaction of work-life balance are correlated with lower levels of relationship satisfaction. So again, we have seen, or all of us probably know a story where the relationship was affected by the work, especially if you're a healthcare worker. Significant others who reported dissatisfaction with the relationship were more likely to report frustration with work-life balance and more likely to report their partners having higher levels of burnout. So here's the burnout is high and is high for everyone. And it has tremendous personal and professional consequence. And how do we improve this situation? What policies should change? And this is just, again, something for us to think about. And we'll explore this in a little bit as we have a bit more discussion around this. But just something, just planting the seed as food for thought. Now, medical education in the time of COVID really is dramatically changed. I was just in a meeting just before this talking about absence policy because students, it turns out, are missing more learning experiences by virtue of just saying that I think I might have COVID, so I won't come in today, right? And what do we as faculty say about that? Okay, but that's happening quite a bit. So everything is transitioned from, to online formats. There's small group formats that convene online in virtual team settings. Clinical skill sessions. I know we were teaching online, like how to hold a stethoscope and listen to your heart. It was the weirdest thing that teaching a student via Zoom. Here's how you listen to a stethoscope, through a stethoscope, and here's what you're listening for. And one of the things is that the transition from the workplace or medical students to a home results in isolation, increased use of email, and struggles with establishing boundaries between work and home. So I'm here today, I'm working from home, and like it's like it's actually very hard to like, okay, I got to focus in on my work because I'm at work right now and not at home. But when you're at home, then it's easy to sort of do other things, and then when you want to really be at home, and then you say, oh wait, let me check my email. And that's certainly my narrative for many days of the year, is that. So, in summary, this job has cost my health, my family, and my soul. Can I get a receipt? That's where we are. And a lot of people are feeling this way. So let's talk about resilience a bit. Resilience is a person's ability to adapt successfully to acute stress, trauma, or more chronic forms of adversity. Resilient individuals are tested by adversity, and they continue to demonstrate adaptive, psychological, and physiological stress responses. And this is what the late Bruce McEwen coined as psychobiological allostasis. So allostatic load is the inability to adapt. When you have increased allostatic load, you are not able to adapt to the trauma or stressor in front of you. Well-being is a multifaceted definition. It has a presence of positive emotions and moods like contentment and happiness. It's the absence of negative emotions like depression, anxiety, and satisfaction with life, fulfillment, and positive functioning. And again, this sort of like if you have too many challenges, you're going to be burned out. But if you don't have challenges and you just have resources, you're just going to be bored, right? And that's what we're sort of always seesawing between. And it turns out that you can both, as I already mentioned earlier, you can both be resilient and burnt out. The most burned out physicians are actually quite resilient as well, or vice versa. The most resilient physicians actually still have pretty high rates of burnout, as you can see. So yes, there is a bit of a step fashion, but they can also both coexist. And again, they're able to adapt when changes occur, resilient individuals, and they are able to bounce back after injury, illness, or other hardships. Okay. So, one of the things I became more interested in thinking about is this notion of mindful awareness. Are you aware even of where you are? And mindful awareness is Ron Epstein defined as to become more aware of one's own mental processes, listen more attentively, become flexible, and recognize bias and judgments, and thereby act with principles and compassion. It's the ability to observe the observed while observing the observer in the consultant room. So knowing where you are in relation to the other is one part of it. And then this requires mentorship and guidance. And the reason is that what makes medicine so special and so difficult is that medicine informs and transforms not only the patient, but we are seeing in very concrete ways that it also transforms the provider. Part of the reason for this, that meaning and values underline professional behavior and commitment. And when there is a misalignment, that leads to a sense of a lack of safety and lack of stability. The integration of professionalism in a personal identity requires a safe learning environment, and healthcare providers have a genuine commitment to healing and service. It's just that somehow over time it gets put away, and that creates a sense of angst in the individual. And why do we need to worry about this now? Because if we don't do this now, we won't ever do this. And the skills, priority, values, and determine a personal philosophy that integrates professional, personal, and spiritual domains. And if we don't do this early in training, it's much more difficult to have that balance occur later in life. Now, there are 10 factors. This is done by Steve Southwick and the late Steve Southwick and Dennis Charney. And they wrote a book thinking about resilience, on resilience, and they describe these 10 factors: a sense of optimism, the ability to face our own fears, having a moral compass, which means being able to align with what feels right for you, sense of spirituality, or something being connected to something greater than oneself, having social support, having role models around this, and having physical and being able to do physical and mental exercises, and so and having flexibility and acceptance and meaning and purpose. So again, these are the factors, and again, all of these are important. And one of the things that I've been focused on is meaning and purpose. That when I found that when providers lose a sense of meaning and purpose, that becomes a tumbleweed for downfall of that provider and not enjoying their work and other sort of important professional consequences. We know that some of these mind-body strategies do work. This is an old study done by at UPenn by Stephen Rosenzweig, and found that it was one of the first studies looking at medical students and looking at a mind-body program like mindfulness-based stress reduction in this population, and found that there was something there, and it actually helped. And one of the things that we've come to appreciate, that when we're doing these, any type of dialogue around well-being, has to be in the dialogue of, this is a shared responsibility between the learner, the school or the academic health entity, and the society at large. And really, they all have parts to play in how we think about well-being. We recently had Dr. Victor Zhao give a talk at one of grand rounds that I lead at here. And he's the president of National Academy of Medicine, has really taken on clinician well-being as an important national priority. And at the organizational level, this is about integrating the work of chief wellness officers or clinician well-being programs into command centers. It's ensuring the psychological safety of clinicians through anonymous reporting mechanisms, allowing them to advocate for themselves, sustaining and supplementing existing well-being programs. So don't drop what you already know works well there. And then at the national level, allocating federal funding to care for clinicians who experience physical and mental health effects, and then allocating federal funding to set up a national epidemiologic tracking program to measure clinician well-being and reporting on outcomes. So this is the sort of national strategy that is happening. So this really reflects a conceptual model. You have negative inputs like stress, internal conflict, time, energy demands, and they have positive inputs like psychosocial support, having social or healthy activities, mentorship, intellectual stimulation. And depending on how these, you either are shifting towards burnout or shifting toward resilience. So in the next sort of few minutes part of this talk, I want to just talk about several pilots that we've been running. This is one is sort of what we've done at the Harvard Medical School, and then I'll talk about what we've done at Mass General. So as some of you may probably know, there is an LCME requirement that a medical school has in place an effective system of personal counseling for its medical students that includes programs to promote their well-being and to facilitate their adjustment to the physical and emotional demands of medical education. And I know that you're the Center, Resiliency Center for George Washington. And one of the things to just think about is that how does the work you do directly address this LCME requirement? Because this gets an impetus for, this really shifts the impetus for why this is important when you have an external regulatory requirement. That certainly happened in my case, that all of a sudden, I think my sense was that Harvard Medical School got dinged on this. And then all of a sudden I got a call I remember in July of 2018, saying that we want you to do a resiliency program and I got a call from the dean. So that I think in retrospect, I feel it gave them an opportunity to say that, yes, we are doing this. So there, one of the other things that we, here's the example of we work very closely with the Office of Student Affairs and how to both provide group-based work as well as individualized consultations. Healthy nutrition is important, and that we've run through the medical school experience. We talk about healthy nutrition habits, the practical dimensions of it, how to get it, where to get it, how to prepare it, and we have several providers who really work with students on that front. The creative arts, this has been another huge area, whether it's through music, through drawing, any other forms of creative arts, but that seems to inspire a sense of well-being through the creative spirit. Mindfulness and mental imagery programs, like the SMART program that we run at the Benson Henry Institute, which stands for Stress Management and Resiliency Training, or MBSR. These programs, which stands for Mindfulness-Based Stress Reduction, they really facilitate perspective taking. So what ends up happening to a lot of students is this, right? Meditation's too hard. How do you keep one thought in your mind for this long? And the other one is certainly has a focused attention, and it's interesting to see what they're focusing on. So, this fell out of place. Another example of some of the programming we do at Harvard Medical School is around mindful movement as well. So let's talk a little bit of the experience at Mass General. I'm, as was mentioned in my intro, I'm the director for the Office for Wellbeing in our Center for Faculty Development. And the Center for Faculty Development's purview is really anyone on the faculty spectrum, from graduate student to full-fledged professors. So here's the current list of things that we do. We have meditation Mondays, every Monday morning from 8 to 8:30. I typically will guide those. And then this, again, anyone in our hospital community can drop in and do this. And this is really, I think, created, what I've seen is creates a sense of community and a sense of regular predictability, which is what a lot of people are looking for. On Wednesdays, we have midweek meditations where we actually invite a different guest leader from our Mass General Brigham community to lead the virtual guided meditation. And so this has been really popular amongst my colleagues to the point that we are sort of lined up all the way to well into the fall, into September, as the openings for people to serve as a guest leader. But this has also created diversity of voice, diversity of experience, and I think that's been very helpful for the employee colleagues. And then one of the things I'm most proud of is this TEDx MGH series. We actually have developed a formal TEDx talk series. We have released a talk roughly once every other month, and these are 10-minute talks. Really, this is very follows TED style. We have it internally firewalled so it's only for our hospital community, not meant to be broadcast outside of our hospital community. And I think that creates a sense of both safety and that you belong. I think people they have a sense of wanting a sense of belonging. Here's an example of a couple of postdocs that have done their TED Talks. So if this was a few months back. And this is another one who's the division chief for endocrine here at MGH, and he just had amazing. I would never have known this about his life, and his talk was just out of this world when he talked about the caregiving of his two sisters who have special needs. And then I run a series of well-being education grants. These are small grants, $750 grants for individuals to pursue some activity or skill around building their own personal resilience and well-being. And the average request, turns out, is about $500. So people are not even wanting the whole, they just want a sense of that they are being seen and they're able to do what they choose to do. And it has really gone a long way for us. I've actually been surprised by some of the positive feedback that we receive in doing this program. And then we do have a sort of centralized page here on well-being. I imagine you do as well. And this has been important for people to have a one-stop shop. But it's a lot of work because you have to keep updating things. So again, we've been working on a shoestring budget. And hopefully in the future, we'd have somebody dedicated to just manage this. And then the Fun Fridays, this is at the noon hour. It's a refreshing midday break from work to indulge in physical, mental, and creative activity. We do this every other week on Tuesdays. And then last but not least, we run, this is our chair of psychiatry, Maurizio Fava, and each year we run a lecture on well-being. And as I mentioned, this past year was Victor Zhao as president of National Academy of Medicine. And I do see individual colleagues individually. It offers sort of a non-mental health space, but yet they're addressing their sense of health and well-being. So I think, I don't know, I think we keep it only because it allows people to enter the system at the most comfortable way for them. For the community at large at Mass General Brigham, we started offering the Stress Management Resiliency Program, which is led by our clinicians at the Benson Henry Institute. And really their opportunities to build self-care and resiliency skills. And we've even developed COVID-19 specific tools as well. Now I want to just run you through briefly just an example of the resiliency program. This was an 8-week program that I did in collaboration with my colleague Peter Wayne. We looked at it was an 8-week, 75-minute session, which included a 20-minute experiential mind-body exercise, and then they were instructed to do a daily meditation, and to sort of reach out for support when needed. So this is the Promise 29, which we've used, and you can see that the before and after most prominently is after, which is in beige. Social participation is higher. Things that are lower post-program include fatigue, sleep disturbances, sense of depression, and anxiety. So this is actually showed that when people engage in this type of mind-body skills, it actually does impact them. They're also not predictive of burnout. So you can see they start well above the threshold of predictability for burnout. This is using the Mayo Clinic Wellbeing Index. And post-program, they drop below the threshold. So, wanted to give a few just testimonials. This course has revolutionized my worldview. It seems that a strong statement, but I've truly sensed about managing my stress anxiety. And I think these tools are absolutely essential to navigating a high-stress academic environment. And you can see that there are other comments as well, really focusing on allowing them to be their best selves and focusing on them. This program, in this individual, both academically and professionally, this program has improved my experience of every situation that happens. I've come to realize better the responses I have towards good or bad situations, and this way being able to process them better. So sometimes it can feel like this, like we're trying to do this and this and this and this and this, and it can be overwhelming. And that's where the space that we offer through through my Center for Faculty Development had, doing consultations with individuals in our community, to really you don't have to do everything. Start off by doing just one thing, and that's often hard for a lot of people to realize or accept or want to do. They want to do it all in the shortest amount possible. Doing less is more here, with intention that this is a lifetime work that you're doing. So going back to this mandala that was created by the National Academy of Medicine, the blue represents sort of personal level, individual level things, and the yellow is sort of society level. And I think, again, all of these dimensions are going to be important. So there's been sort of publications from Australia and New Zealand on sort of medical student well-being and what are the factors that go into thinking about medical student well-being. You want to design peer support curricula that promotes peer support and progressive levels of challenges to students, employing strategies to promote positive outcomes from stress and help others in need, creating assessment tasks to foster well-being as a learning, providing mental health promotion and suicide prevention initiatives, physical health promotion initiatives, And so ensuring a safe and health promoting culture for for learning on in-campus and clinical settings. And so this is really about creating a new culture in medical education. It's about a sense of belonging. I mentioned that earlier, moving away from social isolation or social inclusion as reward, and learning environments are not free from hostility, exploitation, unequal treatment. Having respectful inclusion, preparing an innovative and representative workforce, addressing health disparities, advancing science, and serving the needs of the public, and then a sense of disparities. The American Medical Association also has a position of well-being initiatives. It recognizes that there's shared responsibility, we have to measure student well-being, optimize the curriculum, control medical student debt, optimize the learning environment, and cultivating community, promoting self-care and resiliency, providing for adequate resource for those already affected by burnout or distress, and funding organizational science around well-being. And you can see this is very similar to what the National Academy of Medicine proposes as well. Now, the new word, we're really people have gotten tired of the word resiliency, it turns out, at our institution, although that's still what we're using, but just there's a reality here. And the new word for many people is about flourishing. And flourishing has multiple dimensions to it, but happiness and life satisfaction, physical, mental health, meaning and purpose, character and virtue, and having close social relationships. So this is a beautiful piece by Tyler Vanderweel in JAMA, and it's reimagining health, flourishing. Like, are we talking about health in the context of flourishing as opposed to survival? So I want to end here just talking a little bit of my own personal journey and part of this, to help me understand well-being, I had to understand what made me feel well and what didn't. And one of the things for me was at the time for my daughter, who will now be 8, my wife at the time and we were trying to start a family and recognize that we had to go through IVF ultimately to do this. And it's a roller coaster ride going through that journey, but we ended up being successful in getting pregnant, and everything was going well. We ended up then learning we were having twins, and then roughly around week 20. And as a physician, you are really like fearful of that view that happens when a technician or a provider says, "Oh, let me come back in just a moment," and they have that look like, "Oh, something's not right here." And we ultimately learned that our twins were dealing with a condition called twin-to-twin transfusion syndrome. We sort of did everything for them, but ultimately we lost them. And that was one of the most difficult moments for me, because in that moment I became a father when I held these 2 twins in my hand. They were the size of the palm of my hand. That I became a father, and as a physician I was completely helpless. I couldn't do that. That had to continue the path of their sort of presence in our lives. It really was going to evolve into something else. When we had our daughter a little less than a year later, it turned, we would honor this moment with our sons, and when we got involved, like, there is no greater joy for a daughter. For a child to let go of a balloon. There's no greater sadness when a balloon flies away on its own. But if a child willingly lets go of a balloon, it's a sense of joy. And so one of the rituals that we often did was to, every February 9th, we would release 2 balloons. And you can see the joy on her face and in terms of being able to let go of the balloon. And we've tried to do that every year, just again, but for me it also helped me reclaim my sense of faith, that there's a power in ritual, and helped me reclaim my sense of faith in that, and having more faith really helped me then address my grief and my sense of loss. So one of the things I encourage, if we were to have a bit more time here, is to think about, like, where do you find your support? Who supports you, especially in these moments? And we do an exercise called social support with, and go through a program where we identify both the directionality and intensity of the support. For me, the other piece that was been important to think about well-being was remembering my meaning, and in the context of having support. So once I know where my support, for me, my support has been my family. Over the years, having lost children, having lost relationships, all of these things affect us as humans. And it only made me serve to remind me that if things were this difficult in the home environment and things were difficult in the work environment, wow, that's a setup for not a very good or healthy outcome. Again, this is just example of family support that has been really critical for my sense of well-being. And family comes in different. These are my college, some of my high school and college friends, and we get together. And again, having a sense of like belonging is a part of this. But the one critical anchor for me over the years has been my director and mentor, Dr. Greg Fascione. Here, this is sort of us taking, it was my first time taking him to India, where we gave, both of us gave keynotes at a conference. And, there was in my, when I negotiated my job, I said that I want to be able to meet with him on and for me, our sacred time has become the Fridays from 1 to 1:30 every Friday. And again, not that we meet every Friday, but knowing that I always have that's my time with him, that even through these difficult moments really helped anchor me and keep me well. But students are also important parts of where I find support. So through learners and, this is all pre-pandemic, but I would have them over for a meal and just, light conversation. And it's just been amazing to be also invited into their discussions. Sense of community as well. And it's just amazing to be around smart human beings. You're always learning. But faith is an important part for me, has reemerged as an important part of where I find support. And again, I've been learning to talk more openly about for me, why it has been important for me. And faith, it can, even from secular perspectives, can really represent the sense of connection to something greater than oneself. And where do you find that? So I say, don't be afraid. And you've been fooling around with alternative medicines, haven't you? I love this quote by Pablo Picasso: "The meaning of life is to find your gift. The purpose of life is to give it away." So, all right. So gratitude to all of you for being here. And I thought we can pause for a moment and see if there are any questions.
Thank you so much. I know that resonated with everyone here. And I would add to that, some of us are fortunate, like you clearly are, Dashawn, to have support systems outside of work and inside of work. And that is really the magic there. If you can have a good support system inside of work as well, you have found a wonderful place to really contribute your gift.
Yeah. No, and I agree. I mean, and I didn't realize that until now. And in right now, my Center for Faculty Development role as director for our Office for Wellbeing, a lot of the issues I deal with is, mentorship or lack thereof, and really how that contributes to a sense of not feeling well. But when you can struggle, but it's okay to struggle on a grant application or even working through a clinical. But when you have just knowing that you have a mentor or somebody to support, that was an eye opener for me, and what that meant and felt, especially as I went through some of the challenges in my own life. So.
Excellent. So I would encourage anyone that wants to say anything to just unmute themselves.
Darshan, I just want to say thank you for sharing story of where you all are at, and also your own personal life story. I guess I just wanted to comment that I was I really like one of the things that you said in regards to being willing to start small, and small can be big in terms of like kind of disciplining ourselves to do that and to think about that. And I have been thinking more and more about one of the things that you talked about. Yes, we are resiliency and well-being center, but depending on, because the more talks that I've given recently, resiliency, you have to be careful how you use it, because a lot of people, and rightfully so, they have, if resiliency is used in the wrong way to just kind of get people to continue to do more work and burn themselves out, people have an issue with that. So I thought it was very interesting that the discussion of flourishing. Very interesting. But there are, I could talk to you quite a bit about many elements of your presentation, but thank you so very much.
Oh, thank you. No. I just want to say, yeah, the word, word vocabulary continues to evolve. And I think it's important to us. We may, so one is to really evolve with the language, not necessarily stay stuck on a particular word. But you can also acknowledge a contribution of that word to the vocabulary in creating space for these dialogues. So I think of like mindfulness is an interesting word. Like people have very differing views on the word mindfulness, but it opened this possibility of new language that we never even had in certainly in the medical professions. Like this word, like the fact that I can say to yesterday morning, I always lead our Monday morning meditations, and I do like this is like a normal word in our landscape at MGH, which I never could have imagined being possible, a decade ago or when I started this job. And here it is, like this is what I've been doing for 3 years now. It's like and I agree, the small things actually have made, because people know that okay, that's predictable. And I think in times of uncertainty, predictability is quite I think feels stabilizing for many people. Yeah.
Darshan, I want to say that predictability and consistency, what really resonated with me. Lorenzo and Lee know, like, this is my saying. I want things to be offered consistently so people know it's there, whether it's one person or 10 people, doesn't matter. Right. So, and amazing, powerful story that you've shared with us. Just manifestation of how that personal journey can move into touching so many lives that you're doing right now. So thank you so much for this gift.
No, thank you, Victoria. I appreciate you saying that. I don't know when it sort of clicked for me that why am I afraid of sharing my journey? Because if anything, while my journey is my journey, it allows people to find their own voice for their own. And they don't have to necessarily have to share it publicly or anything, but I think it gives a sense of like, I have a way I can own this. This is part of who I am, as opposed to it feeling like it's something that's being taken away from me. And I think that's the sense that in medicine, one of the challenges that we face is that things are taken away from you. You don't have control over your schedule anymore. You don't have control over this, or you have to do that. So when you get, these are, again, very humble attempts of creating spaces of agency. When people share their own narrative, they own it fully. When we do these TED Talks, they're just amazing. Like this last one was just a tearjerker for me that we just released just last week, which was one of our ER docs whose great-grandfather, who she never met, was and she's of Chinese American descent. So her great-grandfather was originally in China, developed the mask. He was the inventor of the mask at the time of the epidemic that it was going on. This was the Spanish flu epidemic. So he invented the mask, which he was completely ridiculed for. And here we are. And then there was a lot of anti-Asian American sentiment. And she was saying like, wow, here we are, we're dealing with the mask, and why it became a symbol of the pandemic and some of the anti-Asian American sentiment that she faced as a physician. And then how she then changed it into a narrative, her connecting with her young daughter, who was like 6 or 7, who wrote a children's book on her great-grandfather. So a pretty amazing story. And so they publishing a children's book. And that's it. So you see these like stories, and we would never have known that had she not taken it. So.
Darshan, you had, on the topic of the TED Talks, MGH, it strikes me because other things you talked about, there are many things I'm sure you and your group have a lot to be proud of, but you did point that out. I was curious because in certain ways, I feel it's like that the power of storytelling and also using the peers and the talent that are already there, I would imagine that can have a powerful effect. And I'm just curious if you could just maybe even elaborate a little bit more about the evolution of that and how you've maybe different things you've seen with the talks.
Yeah, no, I think, yeah, it is. So we have at MGH 26,000 employees. We know that our TED Talks, because it's open, it's only available to, you have to be sort of inside the firewall. We do that intentionally because one, it creates a sense like belonging, like this is sort of our own people, and people can access it. You have to sort of be part of the community to be able to access it, so to speak. But these TED Talks have been accessed right now, roughly, we estimate, if we had to do about by 5,000 individuals. So that's it was like a pretty good reach. Some talks obviously are way more popular, it depends on, but it's just nice to see how it reaches people. Our investment, people, this is is that we actually coach them. We help them prepare their actual script for their talk, give them guidance, but it's their talk. They ultimately, it's not like we want them to really represent their voice and what they feel is, but obviously there's a time constraint, 10 to 12 minutes. So there's a whole series of sort of operational sort of admin support, but that's what I had to advocate for in my role. Like, okay, we have a senior project manager who's a very good writer, and so she will really work with people to give edits on their talk, and then I have admin support to really do we have a film crew that does a professional sort of film crew. Again, we use internal hospital resources. These are, as I imagine most academic big centers will have their video staff and stuff, but they like it. Like, this is sort of not their usual project that they do, where they're recording a sort of a donor event or something. This is like something that they feel is really different. It's a different line of work, and they're really, so we got the benefit on that of having sort of not having huge expenses, apart from but we have now dedicated budget towards this, which has been well worth the investment in it. So, which is a very modest budget, just to be very clear. It's a very small budget. And then it's a CVable activity. So that's important for for the faculty. They can say that this is a talk, and it's there's a section on our CV like public. It's a public talk that they're giving.
That's CV. Okay, you said I didn't know if you said CME also, but
no, that's CME. CVable. Yeah, I meant to
CVable. Yes, absolutely.
Yeah.
The C currency. Yes, absolutely.
Right. Which is important to faculty.
Yeah, absolutely.
Yeah.
Absolutely.
But it's a very different way. They didn't think of this. It's a very different way of doing a talk. So. Okay.
I'm pausing because I know Lee has done a lot of work with Dean Haywood here in terms of looking at our promotion criteria and how we can start to put in different types of, if you will, multimedia experiences such as this lesson.
Yeah, absolutely. Yeah.
Yeah, it's very important for promotion and tenure, but I think that's even more important for early career members. Yeah. And so we, as mid to late career members, need to focus on helping bring the people behind us up. Yeah.
And for us, it's been a sense of community building. Like this, like my experiments are different experiments of community building. We have meditations. It's a community building activity. We have this TED Talks as a community building activity. So we have all these sort of different, that's what we've tried to do. Well, I mentioned we have these small well-being grants. Again, it's really about, I'm part of this community. So.
With you, I really like your focus on working, you're using experiments, but this idea around, but the central theme is community building.
Yeah.
Community building, and knowing what the effect that can have not only on reducing burnout, but fostering engagement as well as resilience. Your institution, probably similar to many others, including us at GW, sometimes we can have silos, like,
Right.
we have this program, we have that program. And I'm curious in regards to, just in terms of what you see in regards to those community building,
Mhm.
like crossing those boundaries, whether it is, I know every institution is different, whether it's between different programs, it could be nursing, medical students, PA, OT, PT, faculty, staff, the whole thing. But I'm curious about your, like, the efforts to build community across those, if you will, lines, I'll say at times. Yeah.
Yeah, it's hard, say because we are very entrenched in silos, right?
Mhm.
So and so to break down, we're just trying to make these sort of linkages or and sometimes so I don't want to say that MGH is in that sense very similar to all the other institutions represented here. It is one of the reasons why people, and we're in a very difficult situation where people are leaving all the time,
Mhm.
our institutions. So part of it is that they don't feel that they're valued. And when you don't feel valued, or you don't feel you're part of a community. So the answer is I don't know yet what we're doing, because the rate of sort of bleed is right now greater than what we're trying to do to stop the bleed. We're putting our efforts in, but obviously it's a multi-dimensional effort. Again, as I mentioned from the outset, the organizational responsibility is critical, and that stems from leadership. We are becoming much more centralized in terms of a corporate culture, and that was good to help Mass General Brigham align themselves, but it's bad because people feel things have become more corporate. And I think that's a challenge that certainly at the higher levels of the C-suites they're dealing with.
Well, Darshan, just because we're recording this,
Yeah.
and I really appreciate your candor in regards to what you said, particularly for anybody else who might be happening to listen to this, any like people in our positions. I concur with everything that you said. I think that we all across the, I can speak for GW, we are all facing similar challenges in regards to the attrition,
Right.
in regards to, if COVID taught us anything, people have choices,
Right.
and how leadership is going to respond. But I just want to thank you for just like sharing that. And from GW, I echo that, in that we are facing many, if not of the same challenges. So I think that whoever's listening to this, whoever it is, you're not alone. You're not alone. So, but I thank you for sharing.
Yeah. I know our time is up, but I just want to say thank you for inviting me, and I'm happy to continue this dialogue, after this as well. So I think people have my contact info, but if not, Lee, feel free to share it. So
Absolutely. We will definitely take you up on that. Thank you so much. That was absolutely engaging.
thank you. All right, well, great to be with you.
Have a great rest of your day.
All right, take care. Okay, bye.